Well, thank everyone for being with us here tonight for what should be an opportunity to really celebrate the lives of courage and what how difficult it is to be a true proponent of the social mission, to stand up for gender and racial equity in these challenging times. It's still not easy, even though people are watching. So without further ado, I'd like to introduce our first speaker. Um, our only speaker, actually, is Dr. Stella Safo, MD, MPH. She's the founder and executive director for Just Equity for Health. Dr. Safo is a Ghanaian American physician. She's board certified and she's practices doing HIV primary care and also is a public health practitioner. She has led teams dedicated to healthcare improvement in various settings. She really puts her money where her mouth is. In 2021, Dr. Safo created Just Equity for Health, a healthcare improvement company that uses advocacy, education, and care model design via her company, Safo Consulting, to ensure equitable care delivery across all sectors of medicine. Dr. Safo has a deep passion for racial and gender equity and for health as a human right, as a basic human right. She trained at Harvard for her BA, her MD, and MPH. She completed internal medicine training at Montefiore's primary care social medicine program with a fellowship in HIV care. Dr. Safo served as Senior Medical Director of Clinical Transformation at Mount Sinai, where she oversaw the initiation of the redesign of Mount Sinai's 50-plus ambulatory primary care centers towards providing proactive patient-centered care under new payment models. She then joined Premier Incorporated, a leading healthcare and improvement company, as their Chief Clinical Transformation Officer, and where she managed a large team of researchers focused on translating innovation from pharmaceutical and biomedical devices into clinician workflows that positively impact patient care. Dr. Safo remains committed to advocacy within medicine in various contexts. In 2018, she challenged her own academic health system to address issues of gender, race, and age discrimination, something that's not easy, even today. Her board positions include Expand ED schools and Just Human Productions. She's a co-founder of Civic Health Alliance, which aims to increase healthcare engagement around voter turnout, and the Coalition to Advance Anti-Racism in Medicine, which is committed to using federal legislation to address racism in healthcare. Dr. Safo is passionate about medical education and racial and gender equity. She serves as a lecturer and mentor for all levels of medical trainees across the US as well as in Ghana. In addition to publishing in several peer-reviewed journals, including JAMA and AIDS and Behavior, Dr. Safo has written for such popular medical media as Stat News and Kevin MD on gender equity and physician wellness. Her advocacy efforts have been featured in the New York Times, the AP News, and the Wall Street Journal. Her television appearances include MSNBC, CNN, Yahoo Finance, Cheddar, and MSNBC. In 2020, Modern Healthcare named Dr. Safo one of that year's Minority Clinicians to Watch. She is a current New York Academy Medicine Fellow. Please welcome Dr. Safo. I'm going to kick this off to our young student doctor, Dr. Samantha.
Hello, everyone. My name is Samantha Hernandez, and I'm an M1 here at the CUNY School of Medicine. So just a quick rundown of how this event will run. We had opening remarks by our dean, Dr. Green. Now Dr. Safo will speak a little, and then we will open up our Q&A session to everyone. Everyone is currently muted, so if you would like to ask a question during our Q&A portion, we ask that you raise your hand, and then we will unmute you, and you can ask your question once called upon. Thank you so much. Now let's move on to Dr. Safo.
Wonderful. Thank you, everyone, for having me. And thank you very much, Dr. Atkinson, for extending this invitation. It really is a pleasure to be here today. I wanted to spend a little bit of time telling you a bit more about the journey to this point, because as Dean Green kind of read off, there are many things that may seem as though the story is easy, and the story certainly was not an easy one. And I think especially for the trainees in the crowd, it's important to kind of hear a little bit more about what leads you to a place like the place that I find myself at today. So I'll start off telling you a bit about my background and training, some of the work that I've done around practice redesign and transformation, and then how that got me to this current focus on gender racial equity within healthcare and to the company that I have launched. So my background is that of a Ghanaian American. And I distinguish that only because I think that there are, in some cases, unfair advantages that we who are first generation immigrants to this country have compared to others who are, either indigenous to the US or who are descendants of enslaved individuals from the US. And it is worth naming that because when we see, especially Black faces, in positions of success or power, there is a tendency to kind of think, oh, all their journey is the same. And that is not the case. I come from a family of many doctors, nurses, nurse practitioners. My brother is a dermatologist. My mom is a pediatrician. And it was my mom who really inspired me to think about medicine, in large part because I thought a lot about how I just wanted to do what she did. And what she did was serve as a community medicine doctor in pediatrics for patients in Far Rockaway. And she chose that particular place because she grew up in a village in Ghana. And for different reasons, when the famine happened in the 1980s, she and my father went to Nigeria for her to complete her training. And she came to the US to give us a better kind of life. And for different reasons, was never able to go back and practice in her home country. And has carried that inability to go back as a sort of mark that she has always instilled in us, that we should do what we can for communities that are historically marginalized. And so for her, that's meant working in Far Rockaway, which has some of the worst health outcomes in New York. And what has been so interesting about watching my mom's experience as a private practice clinician is the struggle that it takes when you are a good, competent, passionate clinician wanting to do work for communities that are historically under-resourced and historically marginalized. My mom sees primarily Medicaid patients, and we sometimes laugh about the reimbursements that she gets, which will total dollars for work that she has done that is life-saving, literally. And this has really kind of had an impression on me when I tell you a little bit more about my experience working adjacent to life science companies or pharmaceutical companies, where for 1 hour of work, you can make hundreds of dollars when the real people, the real clinicians that are in the communities doing the work are struggling with the healthcare reimbursement system that pays them so little. So my mom was really my first exposure and understanding of a theme that I have seen throughout my career, which is that our healthcare system is broken and doesn't work for anyone. It doesn't work for our patients. It doesn't work for our providers. Perhaps the only group it may work for are healthcare administrators. But even that, I would say, is a challenge. And we see the failures of our healthcare system now with this pandemic, which is a topic we can kind of go into wholly. And so with that background of my mom's, experience serving as a community doctor, I went off to medical school and then residency. And I knew that I wanted to do HIV community care. And for me, the focus on HIV is because I was really interested in a population that I could do continuity of medicine with, and a population that, in my experience, people tended to kind of overlook or stigmatize. And I trained with an HIV fellowship after my residency in internal medicine and really thought that that's what I was going to do. But as I've mentioned, there was a central theme for me that had been really bubbling up, which is seeing all the ways in which medicine was not working. And in my residency program in Montefiore, where I went after I completed my undergrad, MD, and MPH degree at Harvard, the thing that I kind of most was struck by was the ways in which the healthcare delivery system that I was asked to be a part of was burning out frontline staff. And so these were individuals who had committed to working in the Bronx, which is one of the poorest congressional districts in the United States, people who had committed to working in primary care, which is one of the lowest paying professions. In fact, when I told my mentors at Harvard that I was going to graduate from Harvard and go off to primary care, they asked me why and what I was thinking. And that still happens today, which is unfortunate because we need more, not less folks in primary care. And so my mentors who were very committed to primary care were unfortunately unable to do the kind of work that they needed to do and feel sustained in the work that they were doing. And I was watching significant amounts of burnout. And I thought to myself, if I, as a young doctor, am entering a profession that's burning people out, am I going to survive in this doing medicine the way that I want to do it? And am I going to survive in this long term? I might survive for a few years, but I don't know how long term I will survive. That for me was really the genesis of what started my interest in a field that's loosely called healthcare redesign, practice transformation, clinical transformation, population health management, lots and lots of terms for it that come down to this idea of how do we fix a broken system. And for me, this was something that I was very, very interested in because before I gave up on healthcare, before I gave up on seeing patients, which I hoped I would never, give up on, I wanted to make sure that I had done enough to really invest in helping to fix our healthcare system. And so my main kind of academic roles were within Mount Sinai, where I worked as a senior medical director for clinical transformation, and then went over and worked for Premier Incorporated, which is a very interesting model that says, how do you translate innovation from industry? So that's life science company, biotechnology companies. How do you translate those innovation into ways that'll actually be useful for people on the front line? And I know as a clinician, when I had worked at Sinai, that I would get told to use certain medications or to not use certain medications, or certain protocols would get rolled out, and I would never fully understand where they were coming from. And one of the things that was really interesting to me is that in working at Premier, working adjacent to life science companies, I came to see where a lot of the money and power from medicine comes from. For better or worse, this our system is a medical industrial system, and there are parts of this system that are built on an incredible amount of wealth that unfortunately never translates down to those who are most proximate to patients. And so I really appreciated my experience at Premier for teaching me about some of that structure. I also found while I was at Sinai that the work of clinical transformation required me to work across disciplines. And so I think many of you will find that in medicine, as you're training, you learn how to work with your phlebotomists, your nurses, your medical staff, your other medical staff in clinics, but we don't always learn how to work with other non-medical disciplines. And for practice transformation work, that was really vital. I led a team that was filled of engineers, researchers, human-centered designers, and our charge was to understand how we could take primary care within Sinai's system from the historic way that it's been done since about the 1970s to really meet the needs of the future. And to kind of understand that, it's worth understanding a little bit about a field of population health management that's affecting all aspects of medicine. And population health management has really been crystallized since the signing of the Affordable Care Act in the early 2010s. And when that went into law and became policy, what the Affordable Care Act said was that they were going to pay for services within healthcare differently. And so instead of paying for fee for service, which means everything that a health system or a doctor does, you get, the health system gets paid for, they were going to pay in more bundled payments and in alternate payments that were really focused on prevention and wellness. And they were going to also pay for a health system to keep populations healthy. And the reason why this was so radical is that it is the reason why I was then able to walk into Sinai with a primary care and internal medicine background and get a job at a system level leading primary care transformation. Sinai, like many other health systems, had a charge of really implementing and instilling procedures, protocols, workforce changes, technology changes in place that will allow them to be a good population health management center in keeping with the changes that were happening in healthcare redesign. And so that was an exciting time, and we did really, really good work that I'm very, very proud of. And that brings me to, I think, another theme that is important to kind of think about, which is there is so much work to be delivered to try to fix the parts of our healthcare delivery system that are not good. And when we think about the structures that we have in place to do that, while they're imperfect, there are some structures through research avenues or administrative structures for us to do the best that we can do. And the thing that I found that is the reason I think I'm sitting here speaking at an event called Lives of Courage is that it isn't enough that we're focused on doing the work. There is also the reality of the inherent structural inequities that are in healthcare and the discrimination that many in healthcare will experience, especially as you try to bring about change. And so my journey in experiencing that really began even before I went to Sinai, which is where, one of the biggest experiences unfortunately happened for me. But even before I went to Sinai, I felt as a Black person in medicine, the different ways that this profession tries to police you. I was told that my hair, which is traditional locks and natural hair, wouldn't be appropriate in certain settings. I would often fear the kind of professionalism card that if I showed up as my true self, someone would say that I wasn't professional enough. I think that these are often something called microaggressions. It's not a term that I tend to use because I think an aggression, especially one that targets, a vital part of who you are, is felt as an aggression. It isn't felt as, there's nothing micro about it. And that was my experience coming into young attendinghood. And then my clinical experience also reinforced the inherent discrimination in medicine. And it isn't something that I think we should be proud of, but it's the way that we're taught. For instance, we have the reality that certain patients within our big health systems get treated in certain facilities and others get treated in other places. So I was just used to our Medicaid patients getting treated by us residents within our residency clinic, whereas patients with private insurance would get taken care of in the faculty practices. Those are things that's the bread and butter of what we experience. It's the water we swim in, and yet the water we swim in is based in these inequities. And for me, it was really eye-opening when I started serving as an HIV doctor to see the ways in which my patients experience this healthcare system differentially based on their level of education, based on their level of connections to others that had power, and obviously based on their race, age, etc. I had a patient who, as a young Black man, the very first time he had sex, contracted HIV. And in sitting and counseling him and his mom about this life that he had ahead of him, he was only 16 years old, this life that he had ahead of him that would involve, lifelong medication. And he had just learned about pre-exposure prophylaxis PrEP. And he kept saying, I wish someone had told me, I wish someone had told me. And as many of you know, the folks who are at highest risk for HIV transmission are Black men who have sex with men, minoritized trans individuals, and now there's a growing body among Black and Latinx women. And yet those are the groups that have the lowest rates of PrEP use. The groups that have the highest rates of PrEP use actually are white men who have sex with men. And so my patient was a living embodiment of the ways in which our healthcare system was not meeting the needs of high-risk groups or groups who are at risk of certain chronic medical conditions, and in this case, HIV. I had another patient, one of my very first patients that I spent time with, who was a 24-year-old young man who was dying of AIDS. And in this country, I've also worked in Ghana in HIV care, where you see people dying, unfortunately, of end-stage AIDS. In this country, that's not very common to see a young person dying of AIDS. And when you learned about his story, it involved a combination of yes, denial, but also challenges in navigating the healthcare system and being lost within the healthcare system, which allowed him to never get the medications that he needed until it was too late. And I had another patient that this really affected me, a person who had HIV, but actually had end-stage renal disease. And it's an important point to think about, which is that HIV is now a disease that we can control pretty easily in terms of the medications we could administer, but it's the other chronic conditions that are of higher prevalence within certain populations that are really killing our patients. And this patient was in his late 30s. Actually, he was my age at the time. He was in his mid 30s, and he had end-stage renal disease, and he wanted to live his life. And so he moved to one of the southern states, and unfortunately found that he could get little to no healthcare in these states that was appropriate for his level of need, and ended up after a few months coming back. But by then he was so sick that we were working really hard to get him back on his dialysis program here and get him back into care as best as we could. And unfortunately, one day on his way to hemodialysis, he went into cardiac arrest and he died because his levels were so off. And these are individuals that are victims of a system that has not been built to support them and help them. They're individuals who are victims of a history that has led us to this point. And it has been a pleasure to bear witness to their struggle, but it has also done, it's kind of opened my eyes or kept my eyes open in a way for the work that we need to do and the change that we need to bring. And so these are some of the experiences that I've had for my patients. And then I think about what I've experienced myself. And within the capacity of serving in the global health department in Sinai, what I saw and what I experienced was really, really egregious in terms of the kind of toxic culture that is set up when you have leadership, both the leadership at the Global Health Institute, but also leadership all the way up to the deanship of Sinai, that doesn't account for keeping accountable individuals that are credibly accused of discrimination. And in this case, it was gender, racial, and age discrimination. And the reason why this is important for us to kind of spend some time on is because what I described to you with those patients is a system that has failed our patients. And you would think that a system that fails our patients, okay, that's bad enough. But what happens when the system also fails those of us that are within healthcare, and also fails those of us that are supposed to be partnered within healthcare and doing the best that we can. And in bringing our complaints of toxic work environments, of verbal abuses, of fear of retaliation, all things that are illegal, really, under the law to our administration, what we experienced was further gaslighting. And what often happens when you are in a big academic institution and you're going through something bad is that you may think, well, it's just me. Maybe no one else is going through it. Or I should just be silent and quiet and see if I can go to the next institution and maybe this will just go away. And every time one of us doesn't speak up against an injustice, it allows it to continue. And the end impact are the patients that I've described to you, are those people who have less of an in within medicine or less of an understanding of this big system. And so what I and the group that we were membered with, who we call Equity Now on Sinai, we actually banded together and said, this is not going to continue and we're going to speak up about it. And we filed a federal lawsuit against Mount Sinai for discrimination and really took our case public because we realized that one of the things that was important was to bring attention to this culture of toxicity that we were experiencing. And one of the things that has been most shocking to me, but it shouldn't shock me, is the number of individuals who came up after we had spoken up and said, me too. This has also happened to me. This was my experience within my lab, or this is my experience with the same dean, or here are the different ways in which, I've been sidelined and maligned for speaking up. And oftentimes those stories were shared with us in kind of confidence. But the validation that it offered was really important to say, yes, we're on the right path. Since then, one of the things that I've experienced that is both tragic, but also, I guess, out of the ashes comes something good, is many individuals who are at different institutions will reach out and will say, I'm going through, X form of discrimination. Can you help me understand how to navigate this system? And it is its own way, its own form of an underground railroad, because many of us are trained to know the medical pathways for a certain disease state, or we're trained more and more to know the social determinants of health causes for different disease conditions. We are not always trained to understand how to navigate a system that is sometimes pitted against us. And these are multi-million-dollar institutions that we're talking about. And so what I've found is that it has been really helpful to provide that guidance to individuals as they've come to us, and to help them understand how to document things you're going through, how to get legal help for the things that you're going through, and then how to start to heal from everything so that you can continue to practice in medicine, because ultimately that's what's at stake. If you think about what I've just described to you with the experience that we had, all of us, that are in the case could have decided that we didn't want to be a part of this anymore in terms of medical care delivery and walked out and done something else. And some people do that. They walk away from healthcare delivery altogether. And every time we lose folks who are highly trained, who care, who are mission driven, healthcare suffers from it and because of it. And so it is important that we are able to kind of keep the culture in a way that allows people to thrive, not just to survive, but to really thrive in medicine. And so it has been a challenge, but also a pleasure to do the work with Equity Now at Sinai, to really advocate for advances around the way that these institutions treat their employees and ultimately their patients when it comes to equitable care delivery. And that work, I think, has opened up a real pathway personally that allowed me to think about this kind of mission that I have, which is to improve the health of individuals who come from historically minoritized populations. And for me, that has meant creating Just Equity for Health, which is a company that I created that has a mission, a three-part mission that uses advocacy, education, and care model design to really deliver on this mission of healthcare redesign that's built on equity. The advocacy portion is important because as I've just described to you, the culture of medicine, and especially the culture in some of these big institutions, is not appropriate for patients and frontline staff to thrive. And so advocacy is needed to really draw at the heart of the issues that are driving some of these issues around culture. Education is important because all of us are still learning. I don't know how many of you know about the 1619 project, but it's a really incredible project that's teaching kind of the original origin story of the United States. And one thing that I have found is, yes, those who probably need to read it the most won't read it, but even those who consider themselves to be pretty well versed in history also need to pick it up. And so for me, education means going back and looking at our medical system and understanding the history of medical racism, the history of medical inequities, and how we've gotten to this point, and making sure that our trainees that are coming up really understand that. And the final portion of Just Equity for Health looks at care model redesign, which describes how we set up the structures that deliver care in medicine. So for example, how you take care of hypertension, let's say in certain groups. There's a series of ideals that go into that and decision points that go into that many healthcare systems kind of just execute with their quality improvement groups. My hypothesis is that there needs to be a really rigorous process that involves using an equity lens to do that work. And so we are partnering with healthcare systems, professional organizations, and other groups to really think about what that looks like and to think about how we start to scale that across multiple groups in different settings. And so I will stop there because I think that this brings us to a good place for me to answer questions in any of the areas that I brought up with a little bit more specificity. Thank you.
All right, folks, so with that, we're going to begin the Q&A portion. So I will kick it off along with Dr. Gold, and then we're going to open it up to the floor. So my first question for you, Dr. Safo, is you touched a little bit, you talked about your Just Equity consulting firm, and I would like to know more about how you integrate your system redesign with equity and diversity, specifically in cultures that aren't open to it.
Yeah, that's a great question. And so I would say Just Equity for Health is not an organization or not, its mission is not to push people who are not ready, because there is an incredible amount of work and energy that's spent in trying to convince people of a reality that oftentimes they already know exists, but they're just not ready to embrace. So for me, I've made a very particular choice to engage with people and with institutions that are ready to start thinking about some of these principles in slightly different ways. You will find in the health equity space, many of us are starting to do that because there is a way in which some institutions want to hire a Black woman doctor and say, well, she came in and she did all this work and now we're healed and we're fixed. And yet the problems continue. And in some ways, you've been used to whitewash the issue. And so for me, one of the design principles is to make sure, and I use different assessment tools and conversations, honest conversations when we start to make sure that our kind of goals are aligned. And then to, the question of how we do this, there's a real focus, I think, and a real need to move from such really important delivery events like implicit bias training, which is a big one, or setting up diversity, equity, and inclusion committees, to thinking about what it looks like to start to actually operationalize equity within healthcare. And we're lucky in that, as I've mentioned, population health redesign, which is something that's coming out of the ways that payments have been made, different. That is something that's a forcing function for these health systems. I'll use health systems as an example. They have to figure out a different way of delivering care. It is with that mission in mind that we can then say, the conversation you just had about health equity within your DEI committee and this work that your quality improvement, group is doing around setting up a heart failure, delivery system, there's synergy there. And this is an opportunity for you to actually set up that heart failure delivery system with an equity lens in mind. How are you collecting the data? Who is being prioritized to get care? Should you actually over prioritize admitting Black or brown patients in because, they tend to be much less represented in the numbers than not. What would that look like? How does your staff understand what it looks like to take an equity lens in doing this work? And so it really, the kind of hypothesis of all of this is that there's a lot of frenzied energy around equity, equity, equity. There isn't always clarity around what it looks like to actually start to make it clear in the way that it impacts the work. And that's kind of the nexus that my work sits in.
Thank you, Dr. Safo. That was a really interesting presentation. I'm Marthe Gold. I just want to ask you one question and then we'll turn it over to the audience. You talk about population health, and in population health management in medicine is different than population health as it's thought about in public health. And I see that you are a co-founder of the Civic Health Alliance. And I wonder if you would talk just a little bit about your work there, which I understand has a lot to do with getting people on the ground engaged and how you think that relates to people's health.
Yeah, I think that those are two great points that you bring up. And so I'll take the first point about the difference between population health management within a health system lens versus a public health lens. And I would say that, yes, they are different. They're definitely different. The goal, and it's exciting that we live in New York because there's work being done by the Department of Health that I think will really speak to this. And they're a client that I'm working with now around this. The goal is to make them not so different, right? The goal is to make it so that, yes, a public health department thinks about the health of a population at large, and they use tools like evaluating food quality, air quality, employment opportunities, really the upstream drivers of healthcare, right? And a health system, when they do population health, do more things around things like how are we setting up the way that care is delivered? How are we getting reimbursed for it? But in the ideal state, what would happen is that in the ways that public health are thinking about the whole population's kind of upstream drivers of health that cause poor health, health systems would do the same thing for their immediate population. And so, yes, they would set up the care models that make sense for, different disease states, but they would also start to go beyond the hospital walls. And they would say, wow, we're seeing lots of gunshot wounds coming in. What's happening for this population that perhaps we could invest in as one of the largest employers in this area that would help those upstream causes? So I would say that there is a way, or my hope is that both population health and public health can actually move to a place where both using their different tools and strengths can really target the upstream drivers, because that's the only way that we're going to start to see changes in health outcomes. If you're only treating people as they kind of, that kind of famous analogy of, folks are kind of coming downstream and they're already injured and you're only treating them by the time they're downstream and no one is going upstream to see what's happening, we'll just be treating ourselves forever and ever. And then for the second portion of Civic Health Alliance, one of the experiences that I've had within healthcare is that there is something that happens when you are an engaged patient, right? When you feel like you are a patient with agency. Those are the patients that come in and they have their list of questions written down. They take notes sometimes during the visits, and they feel like they have control and they have some sort of impact that they can have on their health and that they're co-partnering with you in their healthcare. And then there's a way that health can happen where things are really passive. And the patients, I have some patients who are always like, doc, whatever you tell me, I'll do, right? And the idea with Civic Health Alliance, and the reason why it kind of relates to this, what I'm describing to you about patients, is that Civic Health Alliance says that, yes, health is something that we do within health systems, but the structures that allow you to have good health are often decided upon within the policy world. We are seeing that today more than ever with the discussions in the Supreme Court around abortion rights, because if whatever happens, we will end up in, for those who work in the emergency rooms, or those who are surgeons, you will see people who have come in from at-home abortions who are septic, who are sick, who are dying. And so Civic Health Alliance says we as clinicians see the end stream effects of poor policy that leads to poor health. How do we get our patient populations, our peers, and our communities to really do something about it? And one lever is the ballot box. It is an imperfect lever. It is a lever that I wish that didn't have quite as much gerrymandering and things that really affect people's ability to get to the polls. But it is what we have, especially for local elections. And so it is a nonpartisan organization that just encourages individuals to get out and to make their voices heard so that they can be activated and engage patient populations who elect the kind of health officials, especially local health officials, that'll help them to keep themselves healthy and make the decisions that'll keep them healthy. And so it really comes from this idea of, if you only sit within healthcare, within the insides of a health system's walls, and all you do is inside the system's walls, you're probably not going to impact your patients' overall well-being nearly enough. And so it allows us, Civic Health Alliance allows us to move slightly beyond that and to say, what are the drivers of this and how do we impact it?
Sounds very exciting. I'm going to turn it back to you, Samantha, and to call on questions for other people.
Do we have any questions from the audience currently?
So this is Carmen. Dr. Stella, I think you're a rock star. But I think knowing what you sort of alluded to in regards to your lawsuit, maybe you can talk a little bit about your journey, as besides the legal implications, but the cost it had, the cost, you know, all these things, these advocacy efforts, and you know, I certainly applaud you. You know, and then why you did it, because there was an option to turn the channel, right? To turn away, why you did it and what the cost has been. A little bit about that.
Yeah, I'd be remiss if I didn't also just kind of invite Dr. Atkinson into this space, because she is one of our co-plaintiffs and you guys know her quite well. And I don't want to put you on the spot, Holly, but I just want to recognize and thank you for that comment about bravery, but also just to say there would be no bravery, and I couldn't have done this without Dr. Atkinson and her partnership and alignment and her bravery. And so Holly, like I want to kind of give you a moment as well to answer this question, because I think you may have a lot more to add to it, but I will answer somewhat quickly and say, this experience broke me. I was unwell, and it is something that has changed my life. I am someone who really believed in institutions and organizations, and really just, I saw myself as an academic for my life. I really thought I was going to be a professor of medicine somewhere, and that's how my career would go. And for me, the thing that was most hard was being so disappointed in the response of the institution and in the response of colleagues who saw what we were suffering, who didn't speak up, who were not upstanders, who gaslit us and tried to convince us that what had happened to us and what was happening to us wasn't happening to us. And so I suffered psychological and physical damage from this. It took me years to be okay. It is a different Stella that you're seeing sitting here talking about this normally. It is something that is a trauma, was a trauma, and continues to be a trauma. But it is also something, and I also, you know, I recognize that this is a blessing. It's something that radicalized me, and radicalized me in a good way. And I think medicine won't change until we're all radicalized. I think we will accept some of the BS, quite frankly, that medicine offers us, that again, literally leads to deaths, right? There are people who are dying from what we are describing. And I think that until we are radicalized and angry and directly impacted, unfortunately, we will not be having these kinds of conversations and pushing in the way that we need to push. And so while it has been a traumatic experience and I have had to do therapy, I mean, the work of kind of my village and picking me up and letting me keep moving forward has been tremendous. And again, I count Dr. Atkinson among that village, has been tremendous. It has not been easy, but it has absolutely been worth it. And Holly, I don't know if you want to say a few words on your end.
Yeah, thank you, Stella. And first of all, thank you for being with us tonight. You know that I feel that you are one of my heroines, and I feel so blessed that you're in my life. I think you hit the nail on the head. It was the betrayal of the institution at large, which was so devastating to many of us. The lawsuit has 8 individuals in it, but there were many more who could have joined us, who made the decision not to. And I think I recall, Stella, coffee that you and I had right across the street from the medical school, oh my goodness, 4 years ago now, the first conversation that I think led to this. And we discussed the pros and cons of it. And I think, you know, for me, certainly at this point in my life, I'm the oldest person in the group. I made the decision that this wasn't about me. It wasn't about us per se as individuals, although we do want justice for ourselves. We really wanted to change the system. And sometimes you have to use the law to change the system. So we made the decision as a group to go ahead. As Dr. Safo has said, it's had deeply traumatizing moments. I think it's changed all of us. On the other hand, you know, there's the old saying, that which does not destroy you makes you stronger. And the 8 of us have been an amazing support team for one another. And when we each have a bad day, we're there for one another. And I think that's a lesson at large for everybody here, which is we really are a family. And it is a matter of supporting individuals, trusting individuals, and reaching out for help when you need it. I mean, we text each other and it's like, I'm having a really bad day. Can someone give me a hug? You know, and it works. So I think there's both been a cost, Dr. Green, indeed. But for us, I think we feel at this point, no matter what happens legally with the lawsuit, we have made an impact. We know that. We hear from hundreds of people across the country, and we're making a change, both not only through the lawsuit, but through advocacy work. So all in all, I think it's been very much worth it. So Samantha, back to you. More questions.
Thank you, Dr. Safo and Dr. Atkinson, for answering that question so truthfully. Now let's hear Dr. Abali's question.
Thank you so much for the great talk.
We're not hearing you very well.
Can you ask to get the phone, please?
Is it just me or?
No.
Dr. Abali, you're not coming through very clearly.
Can you put it in the chat?
No, I can't, but maybe
Oh,
you
there you
can
go.
hear me now.
Oh,
Okay,
there you are.
I'm so sorry. Thank you for a great talk, Dr. Safo. I really enjoyed it. And I have a question that was related to Dr. Green's question, but maybe in a different way. So you talk about your mother who has been a mentor to you, and you talk about Dr. Atkinson to be mentoring you maybe during those hard times. So mentors are so important in our, goals or trajectory. How were you able to reach out other mentors than your mother? Your mother was there for you. How do you develop this or seek for mentorship to get to where you are right now?
That is such an important topic. I think mentorship, and then even beyond that, sponsorship is something that is really, really vital to success. I want to say that I have been very, very lucky and that I've had people who have gone out of their way to help me. And I think there's a benefit in some ways from coming from, I guess the world placing you as an underdog, is that people want to see you succeed and they want to help you. And so I'm thankful for that. I would say that what has allowed me to be successful with mentors, mentoring is like dating. You can't be too shy about rejection. And so I found that when I was at Harvard and, when I did my training, I would reach out to people who I was interested in some aspect of their work or in some aspect of their life, in some way that they had done something, and evaluate if they would be willing to chat. And sometimes they were, sometimes they were not. And so I think it's important especially for the trainees to know that, as they say, shoot your shot. It is worth trying and reaching out. Most people find it such an honor to be asked to offer their insights or advice and are happy to do so. Everyone's super busy. And so, yes, sometimes you won't get like a full hour conversation. You might get 20 minutes, but that person, will come back and will be happy to be there. The thing that I think that I have done well, better at sometimes in my life and not so great at other times, is that follow-up is everything when you are engaging a mentor. They cannot remember to reach out to you about that thing that you said you needed, or to check in on you all the time, again, because they may have 6 jobs and 4 kids. And so it's really important that you are, you set up some system that allows you to keep them informed. A mentor loves an out of the blue, this is what's happening, I just got into this program, or this thing went really well, or maybe I'm struggling, I just want to tell you about it. I had recently one of my new women business mentors, I had a challenge with a contract, and I just sent her a note and I said, this contract didn't go well and I'm really disappointed. And she was like, let's set up time to talk next week, and that's the kind of showing up that happens if you're consistent. And so I would say, don't be shy and be consistent in your follow-up. Don't be a stalker, like not every single week or anything, but a couple of times a quarter or something, I think will really be important for people to know that you're serious about that outreach. And then you'll find that mentorship will go from just mentorship to sponsorship, where they really advocate for you and push for you. And it is true that in medicine, like so many fields, it is who you know. And part of the reason why certain groups are more successful in other ways, certain more successful than other groups, is that they have those networks. And so I encourage you to form your networks, form them early, curate them, hold on to them. They may be the difference between, success and not. And so it's a really great question. And I hope that helps.
Thank you, Dr. Safo. Now we have a question from Mr. Solomon.
Dr. Safo, very interesting presentation, and I think you touched on very important points. And some of the problems you talked about will need a lot of efforts in institutional and structural changes. But I would like to hear from you, because you talked about global health. So I want to hear from you about your vision for global health education and how that could introduce students to cultural sensitivity, to managing patients with limited resources, and also learning from countries like Ghana, learning how women in Kumasi, for example, changed cervical and breast cancer screening in Kumasi, but women in Accra were not able to do that. How can we introduce medical students to the field of global health, and how would that change the future?
It's a fantastic space. And I think before COVID, I would have been so enthusiastic to kind of wax philosophical on it. And now I will say that I feel less kind of certain in my global health footing, in part because it's something that I haven't gotten to invest in nearly as much in an experiential way because of the pandemic. And I think it's really important in medicine to kind of say what you don't know. And so I'm going to model that here. I don't know from the kind of theoretical perspective of kind of an approach to global health medical education, but I will speak from my own experience. And I will say that when I was a fourth year medical student, I spent time in Ghana working with colleagues there and doing clinical care. And it changed my approach to medicine. It changed my understanding of medicine. But it changed it in part because my family is Ghanaian. So I was able to integrate in a way that wasn't like an exchange student coming in and kind of doing this and then going away. I would go every year, every other year, and meet with the same providers, work in the same clinic. So I got to really integrate. And I want to say that because I think that there is a natural way in which, unfortunately, as Americans coming from the global north, we can be exploitative in our experiences with global health, which may serve us, but won't necessarily serve the kind of communities that we have gone to partner and work with. And so my experience was really, I think, one that, because again, of my background, I was able to integrate. And what that integration meant for me is that, and this is one thing that I feel very strongly about suggesting, is that I was able to partner in working on efforts with my Ghanaian colleagues that allowed them to get something from it. So for example, we wrote papers and we did abstracts. And that matters because many individuals back home want to be able to say, here's the collateral of what I've built, right? And what I see, unfortunately, in a lot of global health experiences is that students might go for a summer, they'll have an amazing experience, they come back and they themselves will write an abstract that they'll share with their institution, and there's nothing really kind of left for that community that they were with. And so I think whatever is done and however it is designed, and again, I don't consider myself an expert in this, but I would say however it's designed, there has to be a real focus on community-based kind of participatory research, principles, which is, what are you doing in your 3-month rotation wherever that leaves something there? Are you helping to fundraise to be able to send someone from the local community to be trained and become a nurse or a doctor? What is it that you're leaving that allows for that sustainability? Because I think our previous models were built on, unfortunately, on a colonial mindset that is exploitative and is naturally exploitative. And so, I would kind of just offer us an opportunity to think about how we can do it a little bit differently than I think we have done it before.
Thank you, Dr. Safo. I realize we are over time with the event, but if you'd permit us one last question, if you have the time.
Absolutely, yeah.
Wonderful. So I think most students of this generation can acknowledge that the system we are going into is broken. And there's a large debate about whether it needs to be recreated or fixed in any way that it can. But what do you suggest we as medical students do once we enter into the system? How can we make it better or recreate it if we desire it?
I love this question. I love this question very much. So let me tell you why I love this question, because I think what has happened, or what happens sometimes, is that medical students underestimate their power. So I'll give you an example. When we at Sinai were going through what we were going through with our lawsuit, one of the things that really got their attention was when the students talked about how they supported our case. And a student speaker during her graduation speech, with the CEO and the dean sitting behind her, called out the abuses in our case. It was super powerful. And there's a duality in this, and that on the one hand, medical students are still training, and so you can be targeted. And so it's very important that you actually get through school and train, take the time to study and do all the things. But medical students are also incredibly powerful, and you're powerful because you're a paying member of these, large institutions, and so they will listen to you. So I would say that there is the kind of least threatening way that I've seen this done is that medical students ask questions, and for those who are concerned, they ask questions as a collective, and so they'll get with their student body and they'll ask questions about, it's interesting why, and we actually saw this at Sinai as well. They'll ask questions about why is it that the Medicaid patients all get seen at the residency clinic? Can we please talk about this? Why is it that, XYZ? And the asking of questions is frustrating sometimes to leadership and administration, but it's important because it's the way that we kind of keep ourselves honest. And it's why many of us work within academic centers. We want to look at things with a fresh eye. And so I would say that it's absolutely important to just remember that you have power, even though it doesn't feel like it. And to work as a collective, because that often is the way that you are the most powerful. The more voices you have, the better. I would also say that it's I think sometimes when I say this to groups of individuals, they feel like, oh, I have to not only study and do all these things, but I also have to now be like a radical activist. And that's not what I would necessarily ask. But I would say you yourself, as someone who is aware and someone who is educated on some of the principles and issues within medicine in terms of medical racism, structural racism, historic inequities, as a provider one day and as a leader one day, you will make change. And so if all you do is get through your medical training sane and happy and become a leader in medicine, that also is something that is tremendous and huge. But in the meantime, if you like, adding a little bit of spice and petty, the asking of questions is something that is absolutely vital, and I think really pushes us to do our best and to be our best as leaders in medicine.
Thank you so much, Dr. Safo. I'm mindful that we're over time and we've kept you longer than we promised to, but it's really been wonderful to hear your comments. And I hope that if students have questions that you have sparked, that you might be able to receive some emails from them without being overrun with them.
Absolutely, I'd be happy for that.
Dr. Green, do you want to say something in closing?
So thank you. Let me first by saying thank you to Holly, because it sounds like there's some kindred spirits out there, and your advocacy, you're standing up when it's not easy, and being a friend to a more junior colleague, that's so meaningful to so many people. Stella, I think you're a rock star, and these things aren't easy, and it can be really very, very lonely. But I think the fact that the two of you are together really is illustrative of something I've always said. You know, there's 300 million people in this world, and all it takes is one to make a difference. So one person to believe in you. So I thank you very much for taking time today to answer some questions, share your stories. And, you know, my mother always talked about there's three things you own: your name, your word, your story, and your integrity matters. So we look forward to staying in touch. And thank you so much. And thanks everybody else for joining.
Thank you.
Be well.
Good night, everyone.
Night.
Night.
Good
Thank
night.
you, Stella.